Everybody, and welcome to the first session after the afternoon. And we will start with four presentations. The first presentation will be by Dr. Ahmed Kamel from Egypt. He will talk about how to overcome the heavy calcium. Dr. Ahmed, stage is for you.
Thank you. Good evening. After the delicious lunch, we'll start again. This is my talk. About treatment of heavy calcific lesions in the cath lab. 10 minutes. So they told me that I have only 10 minutes. I'll be as fast as possible. So this is our patient. He's a 75 years old gentleman, non-hypertensive, dyslipidemic, chronic heavy smoker, complaining of typical angina on regular effort. Presenting to the outpatient department, his clinical examination was unremarkable. Labs were okay apart from mild dyslipidemia. His ECG and echo were free, so coronary angiography was planned. And this is his angio. This is the left system, as you can appreciate. Here is proximal to mid LAD lesion, severely calcific, as you can see here. This is a cranial view showing the lesion, severely calcific stenosis in the proximal to mid LAD before a small diagonal. And there is some angulation in the lesion. It's not that straight. Here you can see that the LAD looks angulated. And this is the right coronary artery of this patient, distal severe stenosis of the right coronary artery. So after discussion with the patient and the family, CABG is an option, but the heart team decided that PCI is a better option. I was guided with standby rotablation on board. So we started with doing this simple lesion in the right coronary artery, passing the wire, stenting, and this is the final picture of the right coronary artery after treatment. And then we came to the more difficult lesion in the LAD. So wiring with a workhorse wire and trying to pass the IVUS catheter to the lesion, but unfortunately the IVUS catheter didn't pass as the lesion was very significant. This is a volcano IVUS catheter. Actually, we couldn't pass it through the lesion. So what to do in an uncrossable lesion? Just to increase our guide support, use another wire, do granuloplasty, what to do. So we increased our guiding support and we tried to do gentle predilatation of this lesion in order to pass the IVUS catheter and see what is happening in this calcific lesion. So as you can see, the balloon is not inflated totally, so this is an uncrossable, undilatable lesion, if we can say this. So we tried a bigger balloon in order to have more dilatation of this lesion. As you can see, the balloon is not crossing. The first balloon was 2.5 by 18, and this is an NC balloon, 3 millimeters NC. It barely can pass through the lesion, but we try to inflate it as much as we can, aiming to make a way for the IVUS. So this is after balloon dilatation. Still we have stenosis and calcium, as you can see. Then we passed the IVUS catheter. Now we were able to pass the IVUS catheter to the lesion, down to the distal part of the LAD, and tried to pull back in order to see what's happening in this LAD. So this is the IVUS run, the first IVUS run. As you can see, the distal part of the LAD is more than 3 millimeters in diameter. So this was helpful in, to know the actual vessel size. This was helpful for planning of rotational atherectomy afterwards. As you can see, this is a severely calcific lesion, 180 degrees arc of calcium. to the left-hand side. As you can see, again, we are pulling back. So then we decided to go for rotablator atherectomy using 1.75 millimeters rotablator. This is now we are exchanging the wire over a microcatheter. This is the rota wire is passing in the microcatheter in order to start rotational atherectomy. And then this is the rotational atherectomy using 1.75 millimeters burr, trying to cut the calcium. Again, more rotational atherectomy. So now this is after rota. As you can see, there is a very small dissection flap near this diagonal, this small diagonal. And now we are ready for more lesion preparation, pre-dilatation, and stenting. So this is our stent after pre-dilatation. This is a 3.0 by 48. So we were able to pass a very long stent, 48 millimeters, in these calcific lesions. Actually, after the balloons didn't pass, but after rota, everything was okay. And this is after stenting. And then, because we deployed a very long stent, we are now doing post-dilatation with an NC 3.5 in the distal part and 4.0 in the proximal part of this LAD. And then we checked after post-dilatation using IVUS again. And this is the IVUS run after stenting and post-dilatation. Still we didn't come to the stent. Now the stent is here. As you can see in the left-hand side, there is some malposition which will treat afterwards using a bigger NC balloon. So this is a bigger NC 4.0. I think this was by 15 millimeters to post-dilate the proximal part of the stent that was mal-deployed. And this is the final picture after we did post-dilatation for the second time. This is the final picture of the LAD. As you can see, it's STEMI3 flow, and the stent is looks good expanded. So this is my take-home message. Calcific lesions represent a great challenge in the cath lab. Lesion preparation is mandatory before stenting. Intravascular imaging, as our colleagues mentioned earlier, it plays an important role before and after stenting. Rotational atherectomy, orbital atherectomy, or intravascular lithotripsy are very important tools, but you should judge which one is the most beneficial in your case. The choice between IVL, rota, and orbital atherectomy should be based on intracoronary imaging. Thank you very much for your attention.
Thank you, Dr. Ahmed. Thank you, Dr. Ahmed. We'll keep the questions for the end. Our next speaker will be Zamilna Dr. Nizar from Palestine. He'll be talking to us about recurrent ischemia post-CABG. Dr. Nizar, the stage is yours.
Doctor, thank you for the invitation. I'm going to talk to you about one of our recurrent offenders who keeps presenting with chest pains. This is a 55-year-old man who's a heavy smoker, type 2 diabetic. He's had previous type PCI to his left circumflex before he presented again with non-ST elevation MI. His cath showed 3-vessel disease and he was referred for bypass surgery. He's had a lima to his LAD, SVG to RCA, and a diagonal. Later on, he presented again with angina in September 2021. As you could see, his vein graft to the RCA was patent. He had severe disease in the proximal part of his left circumflex. His lima was patent with good runoff distally, although you could see that big branch which has not been occluded prior to harvesting the lima, his other diagonal SVG was occluded. At the time, one of our colleagues have done the PCI. You could appreciate the instant restenosis in the distal circ, which had been treated with a drug-eluting balloon, and he had a stent to the proximal circumflex. Later on, in November of the same year, he presented again with chest pain, which was typical exertional. His stent and the drug-eluting balloon in the left circumflex were fine. His native RCA was occluded, as you could see, but the SVG was patent. So we thought the offender was this branch of the lima which hasn't been harvested. At the time, his left radial, they've tried to go through it, and he developed severe spasm, which we couldn't do the procedure from the left radial, so went through the right radial. We crossed into the left subclavian, and then we've taken the catheter. The decision at the time was whether to coil that branch or to use a covered stent. At the time, we didn't have coils ready at the cath lab, so we thought, well, we could just put a covered stent, we'll occlude the branch, which is what we did. And we had good flow into the lima, and his branch, which was stealing, we thought that what's causing his angina, has been nicely occluded. The patient presented again in June 2022, and he had chest pain. As you could appreciate, there was a significant instant restenosis in the covered stent, as well as disease after that. The rest of his coronaries was completely the same. So we opted to use a drug-eluting stent inside the covered stent and covering distally, which we did successfully. And he had good flow in his lima again. In June this year, this patient was referred mainly for exertion, shortness of breath, rather than angina. Although because he keeps having this significant ST depression and T-wave inversion in the lateral wall, he was referred for recath. His troponin was negative. We've checked his lima, and it was patent, as you could see. The left circumflex has mild instant restenosis distally, but this wasn't a cause for angina. His RCA was occluded as it was before, and his SVG was normal. Thank you.
Thank you.
Thank you, Dr. Nizar, for your nice case. Probably the fault was first from the surgeon, maybe, that not made to avoid the steal from the lima. Let's go to the next speaker, Dr. Samir Ghanem from the Palestine again. Samir Ghanem, and he will talk about ACS and coronary aneurysm. Please, Dr.
Thank you for this opportunity. We will start with a patient. He's 55 years old, smoker, dyslipidemic. He was admitted as non-ST elevation MI in another hospital. He had in the cath lab, this is the cath. Significant LED lesion, bifurcational circ lesion with aneurysm, and a significant right lesion. The patient refused to do surgery, and the decision was to avoid doing PCI due to high risk of perforation due to this aneurysm. He was presented to our hospital, and we decided to do the PCI to the circumflex, because all the prognosis by the next will depend on the successful stenting of this bifurcation. We started with cyan blue, we didn't pass. Then with cyan black. If you see here, the takeoff of the lesion from the aneurysm is very difficult to go through. It's like that. So if we took another more tough wire, the risk of perforating the aneurysm. So it will never turn in order to get to the lumen again. So this is schema of the lesion and the aneurysm. So it's impossible to go in this direction. Every time it's going toward the aneurysm. Now, when we passed, we will find that the aneurysm start to fading. So the question was, how we did it? Why the aneurysm is starting to fading? Which was the mechanism that we did it? You will find this. This is a fading aneurysm, and this is a trait of dissection. The mechanism there, I decided in order to pass and avoid to perforating the aneurysm is to induce the dissection. If I induce dissection, that may possibly to occlude the aneurysm, and I will avoid to do that. Like the same mechanism we are doing when dissection re-entry in the CTO. And this was the mechanism, and we through the lumen, and the endothelium we used was enough to culminate. You see here? Was enough to culminate this aneurysm and to avoid any covered stent or anything else. And we stent that. No more aneurysm, because it was culminated by the dissected endothelium, dissected method we used. It was enough to occlude the orifice of the aneurysm. Then we finished as usual, as then the first OM tap, and I will go directly kissing. We stent the proximal final pot, and this is the final result. Thank you.
Thank you, Dr. Osama, for the nice case. I think we have 1 minute to ask you just one question before the next speaker. Why did you call it an aneurysm based on the size from the start? And was the dissection that you caused planned or just a pure luck? Just one question.
I was asked this. It was pure luck. No, but I tried many times through the aneurysm, and the wire was really very risky to play there. Then when I tried with the cyanoblack, I find that I am not in the lumen, and there is a resistance, and I tried to push down in order to avoid going to the aneurysm. So
okay.
It was started unfortunate and completed intentionally.
Thank you, Sama. Next speaker is Zamina Dr. Ahmed Ali from Iraq al-Shaqiq. He will talk to us about small vessel interventions.
Thank you for the opportunity to be here. Today I'm going to talk about one of the important subjects in our daily practice, which is not well covered, which is the small coronary vessel intervention. This disease or entity, it is present in about 30 to 70% in all population undergoing PCI. It is especially in certain group of patients like females and diabetic and in chronic renal failure. Also in specific situation when we are facing, there is a high incidence of small vessel, in particular when the vessel is distal. The more the distal the lesion, the more the possibility of being small vessel disease. And even when we are dealing with bifurcation lesion management, also the side branch most likely will be a small vessel entity. Small vessel disease carry a high risk for device failure, for restenosis, and there is a need for revascularization. For this reason, even in the ESC recommendation for intervention, they not encouraging the complete revascularization in the presence of small vessel disease. For this reason, it is crucial to evaluate the vessel size before the final decision regarding the management. How we assess the size of the lesion, usually we have main three forms. The first one is the QCA, and we have IVAS and OCT. The most accurate one is the OCT, and with more resolution regarding the assessment. The most recent published article about this disease was published in JSky and is talking about this entity in more comprehensive review, and they consider many trials. This is a busy slide including the majority of the trials that was included, and they compare the complication between various trials and how they manage, whether using drug-eluting balloon or using drug-eluting stent. And the conclusion was that in daily practice, the management of the patient with small vessel disease represents a great challenge. And after, even in the CABG, also this considered. In the era of a new drug-eluting stent, still there is a possibility for being used in patients with small vessel disease. It is effective, and still the risk of thrombosis and complication will be high. But what is important to be considered when we are selecting the stent in this entity is the use the stent with thin strut, because the early gain of the lumen will be better than those with large strut. In a recent meta-analysis, they found that when compared between drug-eluting balloon and the drug-eluting stent, there is regarding efficacy, the drug-eluting balloon is more effective in gaining the initial response, and the restenosis is less, and also the significant reduction in the risk of vessel thrombosis. While on the other side, a recent observational studies shows a conflicting or reverse result, that they show that drug-eluting balloon compared with the stent was associated with significant higher risk of restenosis, and there was a similar risk for target lesion, thrombosis and other complication. The explanation for this result was mentioned that there is a difference in the selection of the size of the vessel which considered to be a small vessel. There is no general agreement about the cutoff size to consider as a small vessel. Here we have the effect on the PCI. Also in the management in form of CABG, still small vessel disease represent a problem. Usually they commonly use the diameter of 1.25 as a reference or considered as small or not. In patients with CABG, it is an important factor for later on complication, and there is an effect considered which is equal in male and female, also in venous or arterial bypass graft, although the detrimental impact it is higher in patients when being female and there is a venous graft. The explanation was that there is a great discrepancy in the size between the graft and the vessel, and this will create a sort of turbulence and shearing forces which affect a long-term survival of this, our integrity of this graft. Diabetic patient also considered a specific entity, and even when there is a small vessel disease, the risk of complication will be higher. Here we are seeing some examples of cases with different scenarios. The first patient He is hypertensive, presented with acute MI in the LID region, and was managed but the patient is still symptomatic. This is his coronary angio. We could see a critical lesion involving the CERC and also the OM. But most critical one is involving the distal RCX, and the management was in a form of coronary intervention, dilatation with small balloon, and then stenting by 2 stents, 2.25 and other 2.5, and this is the end result. So in this patient, the scenario was presented post-MI angina. The second scenario of the patient, here the patient presented with acute coronary syndrome, troponin positive. He was 3-vessel disease. As we see, all the vessel being small size, the CERC and LID, we has a sort of total occlusion. Also, the intervention was a choice because of acute presentation, and the vessel was a small size. Management of the CERC lesion with a small stent, 2.5, and then the LID also managed by the same sort of intervention. And this was the final result. The third scenario of the patient, who is highly symptomatic from the lesion, which is only subtotal lesion in the mid-RCA, which is a small vessel. Also, the intervention was in the same sort of small vessel intervention, dilatation, and then implanting of 2 stents, and this was the final result. So by conclusion, we have 4 important points. The first one is that the visual estimation is the most widely used technique to estimate the reference vessel diameter. And we are advising to use the imaging as a modality for proper assessment in order to decrease the risk of over or underestimation. This is the first point. The second point, accurate assessment of vessel diameter depends on achieving of high state of adequate vasodilatation. So it is very important to consider the use of intracoronary dilator, nitroglycerin, before deciding about the final size of the vessel. In the management of small vessel disease, we have to put our procedure in a simplest way which is possible. The aim is first to dilate with a plain balloon, not exceeding 1:1, in order to avoid the dissection. And if the result was okay, then we shift to drug-elutant balloon, which is also not exceeding 1:1, and the length of the balloon should be slightly larger by 2 to 3 millimeters than the plain balloon to avoid the edge dissection. If the flow not jeopardized and there is no complication, we stop at this stage. Otherwise, when there is a major dissection or TIMI flow jeopardized, then we think of stenting, and the thin stratus stent, which is the preferred. The last point, which is very important, we are in need for general agreement about the cutoff size of the vessel, which is considered to be a small size. And when we are reviewing the meta-analysis, the best size to be considered is 2.5 millimeter, considered as the cutoff value for considering the vessel as a small size vessel. And thank you very much.
Thank you, Dr. Ahmed. Thank you. I think we have 20 minutes for questions, starting with our panelists. Dr. Jamal.
I want to ask Dr. Nizar about the recurrent ischemia post-CABG. Suppose, for example, a CABG patient who has suspected myocardial infarction. How do you diagnose this case in the context of multiple symptoms that the patient always complain? This is one thing. Also, positive troponin, which is commonly seen in these type of patients in the ICU. And how do you prevent any mistake in making the correct diagnosis? I mean, what's your plan of following up post-CABG patients to rule out MI in the first or second post-op day? Thank you.
We're not talking about first or second post-op days. This happened months after, like 2 or 3 months post-CABG. So the rise of troponin wasn't meant to be related to the bypass surgery itself. It's not an acute event. In general, when we get these patients who are presenting with chest pain, troponin is one of the markers that we look at. But we also look at the patient's symptoms, with the ECG, the echocardiography to see if there is any regional motion abnormality. And then based on all these things collectively, we make the decision that this is a true angina or this is not a true angina. And upon that, we go ahead whether to take them to the cath lab or whether we need to do more non-invasive studies to actually decide that this is angina, we need to take them to the cath lab.
Thank you, Nizar. Ahmed. Dr. Saad.
I think I can manage. Thank you. Well, there has been many debates about steal phenomena in mammary artery. And this issue started in late 90s when we started doing off-pump surgery and mid-cap in particular, where we couldn't, as surgeons, reach the first intercostal. And from physiological point of view, the flow in the intercostal occurred during systole, while the flow to the coronaries occurred during diastole. So I heard at that time, in many centers, many places, that it's a myth that there is a steal phenomenon. So I wonder, how can we deal with this without documenting ischemia in this patient, in this particular, in this mammary itself? And what should we do in the future regarding when we dissect or when we take down the mammary for implantation? I'm a heart surgeon. Should we look for an intercostal branch? Sure, we should if we have a mid-sternotomy. But if we have a limited access one, I know many surgeons that do take down, or they just take the mammary to its middle part and leave 1 or 2 intercostal branches, and their patients are doing well. So how sure you were before seeing that branch that the ischemia was definite? Or because playing with the mammary, I mean, this is something classical teaching. Put the mammary, I mean, don't put the mammary sequential, don't play with the mammary, don't. So did you document real ischemia in the territory of the LAD before stenting that LAD?
I think you can't say for certain that the steal phenomenon does or does not exist. I think you need more physiological studies to assess it, to be certain, maybe the pressure wire to the LAD itself through the lemur to decide whether you do have ischemia or not, to be quite certain that this is the cause. I think in our case it was a fairly large branch which was there. It was almost the same size as the lemur, maybe just a little bit lower. The patient did present with typical anginal pain. He had ST depression in the lateral wall, he had anterior hypokinesia. And he also, a couple of months later, he's had the PCI to the left circumflex, which was the only other artery which could cause him angina, and he didn't improve at all. So he had the PCI to the left circ. He's still complaining of typical anginal pain, which did actually improve after we've put the covered stent to the branch of the lemur. How to prevent such a thing? My own personal experience now, whenever I see a patient that I'm referring for the surgeons, I attempt to take a shot of the left subclavian first to make sure that there is no subclavian stenosis, and then I try to visualize the lemur itself so the surgeon can take a note if there is a large branch very proximal, which they won't be able to see during surgery. that he knows, maybe I should clamp this one before I implant the Lima.
Thank you. I mean,
thank you. Regarding the first case of Dr. Ahmed from Egypt, I do think that the IVL will be more appropriate for your case after passing the balloon, even before the rota, if it's available in such situations. And for the second one, for Dr. Nizar, I do think in cases of post-CABG angina, the CT now getting popularity in the assessment of post-angina, especially if it is late one, not an immediate one in such cases. In cases of small vessels, it's very preferable not to say that it's a small vessels in the proximal part of the coronary arteries, because we don't have actually the registry from the Middle East that how much the diameters of the proximal parts of the epicardial branch, but we can say that most of the time is 3 and more in its diameter. So probably if you use the small vessels, term we do use for the mid to the distal ones, and the DCB actually is getting very popular in these type of the situations. If it is available, it's more preferable actually than the stent, because the stent, there will be more maze with the stent compared to the DCB. And for the case of the aneurysm, it was very nice chance actually for such one. And this will be added a value and contribute to the literature in terms of treatment of this challenging item in cases of the intervention. I would like to congratulate you. Okay. Thank you.
If you allow me, Nizar, and so Nizar, I think I would reiterate what Dr. Saad has said regarding those branches coming from the Lima. Studies have been done on the flow in these Limas if you occlude those branches, and the flow was never different. So Dr. Saad's point from a physiological point of view has been proven from studies from St. Louis in particular. And if you occlude that Lima branch, you are not sure that the flow to the LAD will increase. And of course, you can prove that in the cath lab by occluding the branch with a balloon and passing a flow wire in the Lima and see the coronary flow reserve if it increases or not beyond 3. So I'm not sure these Lima branches are any more been advised to play with them by coiling or stent grafts or anything. So my question to you, if that case came to you again, what would you have done differently?
I think I would have taken the time, taking the patient off the cath lab, and as a technique-wise, I would have used coils to coil it rather than using covered stent, which we've noticed later on that it has stenosed, and we had to put a drug-eluting stent inside it. So using the covered stent, I would say this is the right decision to do. Coiling is definitely better. Regarding the physiological part, this was maybe a unique patient who's very sensitive to angina. He's a recurrent offender. He's seen all the cardiologists in the city, and he describes typical angina. He's had multiple stress tests before, which were positive. He's got fixed changes on his ECG, but he also gets significant ST depression with chest pain. When you don't have other targets to go through, and you've got someone who's fairly young, he's 55, he's complaining of typical angina, which is limiting his lifestyle, you would possibly go ahead and do the intervention. I think you take each case by itself rather than saying I would or I wouldn't intervene.
Thank you, Nizar. Dr. Yahya?
Just a quick comments. I think we should probably agree that there is overuse of cardiac catheterization in our region. I always say in Canada, I do 10 non-invasive for every cath I refer. But unfortunately, we have circumstantial also reasons we don't have non-invasive tests or good interpretation. This is why sometimes cath is overused, and unfortunately, once you do the cath, the eye reflex work, and we
Yes.
fix lesion that sometimes
Thank
may
you.
not be necessary.
Dr. Abdullah.
Yes, I have two comments about two cases. First, regarding putting grafted stent in the Lima shaft, I disagree with that because the restenosis and thrombose rate is very high. And I think that there should be collaboration. If anyone doesn't have the experience to put coils in that branch, is to collaborate with the interventional radiology for that sake. Second, regarding the case of the dissection, we saw that the flow was resumed after you stented that. So it doesn't make sense that you occluded that aneurysm by causing dissection, creating dissection, and then you got a normal flow. Because if the flow was resumed, then the dissection would heal. This is the point. So if you created a dissection and occluded that aneurysm, and then use, yeah. You mean that thin endothelium excluded that aneurysm? I doubt this as a mechanism. You can prove it, but I doubt this. The second thing, that using a cyan black in order to enter into an aneurysm like this, I think it's dangerous because it is a polymeric wire and it can cause perforation. Cyan black is polymeric. Cyan and cyan blue, I agree that you use cyan blue, they are non-polymeric. This is the difference.
A question from here.
Okay.
Mohammed.
Can I?
Yeah, if you let Dr. Samir just answer the question.
Just for the dissection, it was dissection re-entry. It was seen by injection. There is a dissection, and the only mechanism that can explain to occlude this aneurysm is the accumulating segment of the endothelium that occluded this or excluded even this aneurysm. The second thing, the cyan blue, I wanted something polymeric with more support in order to go not through the track of the aneurysm, but through another track with dissection. So when I answered Dr. Raed Aqil, was it intentionally, in the first seconds, I find some resistance. When we find the resistance, we pull back and we go back again. When I find dissection, in this time, I will continue in this track, which I know it's not the true lumen. I will continue to dissection. Maybe I will avoid this the track which is going through the aneurysm.
Okay. We have another question, please. We have 10 more minutes, so we have more questions to come. Nice cases.
Thank you very much. I have some questions for speakers. Actually, we start with the first speaker. Just one point, at least to me, I don't understand the one step in your work. I don't, Dr. Ahmed? Yes, okay. You wiring the LID, yes, and then go by imaging, and then go by balloon dilatation, aggressive, and then go by rota. It's safe to go and you create a dissection by your balloon. It's safe to go by the rota and the dissected plan. It's very risky. Possibly might be create perforation. But I think the steps is wiring, imaging, and then rota or IVL depend. And we, so I'm totally agree with you. If the IVAS catheter don't cross the lesion, you can go by the small size balloon and then make a channel for your IVAS catheter. You go by 2.5 and 3 and create dissection by aggressive dilatation.
Open completely. So it was an incomplete dilatation with the 2.5, and the 3.0 didn't go. I tried to open it, but actually it didn't go in the lesion properly. So I was able to pass the IVUS catheter and then went with the route after.
So thank you. So again, we appreciate there is some residual stenosis in your stent.
That's true.
And we appreciate there is some medial calcification. Sure. As Dr. Amin said, why not IVL instead of using rota?
Actually, the IVL is not reimbursed
not
by the
available.
government. Actually, it's available, but it's not reimbursed by the government. Only the rota is reimbursed.
Okay, okay.
If you cannot cross with the balloon, you cannot cross with the IVL.
Yes.
So the point is you need to have some room for the balloon IVL. The IVL balloon is a bigger balloon, so you need a room. If you can cross it, it's okay. If you cannot cross, you can use a rota.
Okay.
Look, for sure, going up front with the rota after failure to pass the IVUS, going up front with the rota is better, as you said. But I prefer to go with IVUS first to allow me to see what's going on.
It's obligatory to go by
yes,
IVUS
sure,
first,
to see whether the calcium is just superficial or superficial and deep.
Thank you.
Maybe I will use IVL in other case if the calcium was superficial and deep.
Thank you, Dr. Ahmed.
Okay.
We
So
have
the second question, sorry, for the second speaker. I don't know, there is no any studies encouraging using of the cover stent in the Lima. Possibly the cover stent might be very useful in the SVG in the recent study, and some studies support use cover stent in the SVG stenosis to prevent the risk of the non-reflow. And the Lima should be dealt with the DAS, not rather than by the cover stent. You know, there is high risk of ISR and stent thrombosis.
Sure.
And the last question for the patient with aneurysm, very preferably to do control angio for your patient. As you said, the dissection healed, the aneurysm healed by the dissection. Once the dissection is reversed back normal or healed dissection, possibly we might get again the aneurysm. So you should be follow your patient by doing controlled angio later. Thank you very much.
Thank you. Dr. Asim, can we have the microphone, please? Thanks. Dr. Nizar, get ready. Nizar, get ready again.
And we know, as Dr. Saad mentioned, Lima patency, and 10 years Lima patency, close to 90%. Graft restenosis, 50%. Yani you put stent graft, half of the patient will come back. You treat the graft restenosis with drug-eluting stents. Do you have any data on long-term patency? Drug-eluting stents in graft, inside the graft?
The first thing, this is why me and Dr. Mahmoud thought this is a very interesting case to bring in.
He tricked you.
Bring a lot of discussion about various management things. So, as I said before, if we are to go back again, we would have coiled it rather than putting a covered stent in. Regardless the patency, well, this latest cath which I've done in June this year, this was a year after implanting the drug-eluting stent inside the graft stent. So in this case, we have a patency of a year with no instant restenosis. This is not a case which you would have had trials and evidence on. This is a specific case. So this is, we put a drug-eluting stent because there's no other options. The Lima is used. You're not going to send the patient for another surgery to put a vein graft to the LAD. So you have an instant restenosis in the Lima, which we had to treat, and treating it was mainly with a drug-eluting stent.
Thank you, Nizar. I guess I have final comment before we move to the next session. Regarding the aneurysm case of Dr. Samer, sometimes the mechanism of disappearance of small aneurysm in tortuous arteries is straightening the artery itself. So it might be the case that with your cyan black or blue that you passed through, you straighten the artery, and that will explain disappearance of the small aneurysm rather than you went through a dissection plan and re-entered the lumen. That makes it more sensible. So.
May I say one word?
I think in Samer's case, you could tell that the wire isn't in the true lumen. It was far away from the normal route or the normal track that the wire took it the first time. The second time, it was clearly not in a true lumen in the vessel. So maybe you're saying is right that straightening can reduce, but in this specific case, I think he was in a dissection flap.
And then we enter the vessel again.
The vessel, and
sounds good. Excellent cases. Yes, we have one more question.
One last word. One last word. May I?
Yes, please, Dr. Mustafa.
No, I'll talk about your case, that of the aneurysm. I think that the lesson I got from this case is that the intima can occlude an aneurysm. We know once you occlude it, the flow stops and it will get thrombosed, even the section heals. I don't think that it will appear again. But this is not a case that is reproducible in its results to make it peace, to learn people to dissect vessels,
to close
to occlude aneurysms. He was lucky, and he was lucky that he got re-entry into the true lumen, because if he couldn't, it would result in disaster.
Nicely said, Dr. Mustafa. Thank you. Very nice cases. Congrats to the speakers. And we can move to the next session now.